I now have the greatest opportunity to introduce my friend and amazing colleague, Jeffrey Mersky. He's going to be, he's a visiting dignitary from Del Mar, California. And come over here, Jeff.
All right, let me take my...
Bring your water.
Yes,
you can put your water here.
Del Mar with the Del Martians.
Yes.
And the Delmaniacs.
And this is where you stand.
Okay, great. Thank you so
Go
much.
for it.
Welcome, everyone. Thank you very much for that lovely introduction from Charles Blum. And thank you to Charles and Richard for putting this meeting on. It's great that we have an interdisciplinary cranial meeting with people outside of our profession, because I think you can't have enough people helping you on some of these challenging cases. And who doesn't have these challenging cases? For me, as a chiropractor, I've been in practice 32 years, and I know a lot, but I don't know it all. So I thought I'd share some of this information with you to go over a case study that Charles actually helped me put together. And it wouldn't have happened without him. And it revolves around a patient that had multiple challenges, and one of which, and not least of which, is a low oxygen situation which caused dizziness. And on top of it, he had a cranial facial TMJ overlay. So when you combine those two aspects, you start to have these multiple issues. This guy has been through multiple treatments. He's been through about 28 or 29 different practitioners, and he's got little to no results from all that. So he's looking around because he says, I'm only 38 years old, and I need to get through the rest of my life in a less compromised situation. So for the next 15 minutes or so, I will attempt to tell you what I did with him, because when I first saw him, I said, what am I going to do with this patient? And yes, while I have the experience, I think what I did was I threw stuff at the wall to see what would stick, and it did. So I want to focus on, obviously, this wonderful slide done by Mark Pick. And better than anything, Mark shows motion into the cranium. And it's the old adage, if you don't use it, you lose it. Loss of motion is the loss of life. And more importantly, with loss of motion, what really drives the whole system is breath. So we know that in SOT, we look at these inhalation and exhalation phases of cranial faulting. And what can I say except the very first thing you're going to do in this life is you're going to take a breath in. The last thing you'll do is take a breath out. And somewhere in between that breath in and breath out is what we call life. So we're seeing our patients in varying stages of loss of motion and loss of breath, loss of oxygen. So what became interesting for me is that I deal with a lot of the local dentists in the area, and they send me patients that have, starting with descending problems, they have TMJ issues, but a lot of them have these ascending issues, so they want me to treat the rest of the body because it's out of their scope of practice. Well, in a subset of these patients, a lot of them did really well by having their airways checked first. It makes my life easier because if you're assessing airway, you can see whether or not these patients can breathe through their nose, can they breathe through their mouth, do they have tongue position problems, do they need a CPAP machine because they can't breathe, they have apnea conditions. So all of these things are assessed and they come to me. Well, you would think if you roto-rooted the nose out, if you took an appliance and put it in someone's mouth with a lingual button on it to push the tongue out of the way so it doesn't roll down their throat, that they're going to do better. And a lot of these patients do. But some of these patients did not. So I couldn't understand why. And the real reason is because this is not just a mechanical problem. We're so focused on structural issues that there are other things that are going on that can really affect the body. I thought that I'd bring that into play. In some cases, we have people who can't breathe. They can get the oxygen in, but they have chronic obstructive pulmonary problems. And on top of it, if they could even get it through their lungs, some of these patients actually have problems with red blood cell count, low red blood cell count. They're anemic. They don't have enough iron, they don't have enough hemoglobin, hematocrit, their MCV, their MCH, their RDW levels are compromised. So just because you can get the air in doesn't mean that these patients can utilize it. And the loss of oxygen basically is a problem because it combines with sugar to make ATP. We burn it in the mitochondria to move the body forward. This is the energetic cycles of the body. So we're doing nothing less than affecting all these patients when we do improve their TM joints and their airway issues, but we have to look at more. especially in the patients that don't really resolve with those type of situations. For me, there's two factors for longevity. Number one is obviously, can you breathe? In 3 minutes without oxygen, you're dead. And the most important test that you can do in all of medicine is testing vital capacity. So also, can you stand in a field of gravity and not fall over is the second one. So what happens to patients as they age, they crash and burn, they break a hip, and they're dead. So the inability to stand in a field of gravity is what's beautiful is in SOT, the category system describes the distortion factors of the body's inability to weight bear. And that's a big thing. So we're addressing the most important things, I think, in the body. So I took it one step further. I said, well, what actually is it that causes death, in our patients besides the fact they can't stand up and they can't breathe? Well, if you want to put a name on it, heart disease, according to the CDC in 2014, that was the latest ones I could find in a comprehensive manner. A close second is cancer, and that might be number one now in 2017. You've got COPD, chronic obstructive pulmonary diseases. You've got problems with accidents, unintentional injuries, and now you've got problems with stroke or cerebrovascular accidents. So what's interesting to me is that the heart disease, the COPD, and the stroke are pure low oxygen states. It isn't the fact that you had a heart attack or that you've got some sort of asthmatic condition or that you threw a thrombus and you've occluded the arterial system. It's that you can't transfer oxygen in the body. Cancer's a mixed bag, and of course accidents are another situation, random in themselves. So for me, when I started to look even further, because we're dealing with all these people with airway issues, 1 in 15 Americans, and I think it's much higher than this because I think a lot of this goes unreported, have apnea, okay? And what's interesting is that snoring is one of the major indicators of obstructive sleep disorders, and 50 to 70 million adults have a sleep or wakefulness disorder. On top of it, untreated cases of sleep apnea face a risk of stroke that's 4 times greater, and also 3 times greater are likely to have a heart attack or some sort of heart disease. That's in the top 5 things that kill us. So we need to be looking at these aspects instead of looking at just mechanical problems. Roughly half of all the hospital patients that have a case of hypertension also are afflicted with sleep apnea, and conversely, half of all the sleep apnea sufferers face a diagnosis of hypertension. How many of your patients that come in are on blood pressure medication? They're on diuretics, they're on beta blockers, they're on some sort of medication that compromises the system in other ways secondarily, but handles the symptom of high blood pressure, which in most cases is idiopathic. And I don't think we're looking at this enough to really assess these patients properly. So I have Chris W. He's a patient that was referred to me from a colleague. He's got an onset of these symptoms back in 2008, and what happened was he had all 4 wisdom teeth pulled, and he's an avid surfer, Southern California thing to do, and all of a sudden he catches this wave and he crashes and burns and hits the bottom of the sand and hits his head and his shoulder. And within a day or two, he's got these debilitating type of problems, which he's never had before. Since 2008, I told you, he saw 28 different practitioners on the 29th. Oh my God, what are we going to do with this guy? And yet, he's only 38 years old, so you got to give these guys some hope. And what I found was that he'd been through acupuncture, he did chiropractic, he did diversified, he did NUCA, he did SOT with me. He also had some ballooning techniques done, which is a subset of cranial work that, I don't know if Adam Del Tordo is here. Is he here? Charles? No. Okay, Dr. Del Tordo teaches this. I think it's now certified up at Life West, so it's a good thing to have in your toolbox. I think it's always good to learn cranial first and understand how the cranium works, but it's a great thing to have this in your toolbox, especially for airway and chronic sinusitis. His father's a chiropractor. I don't know how many times this guy's been treated by his dad over the years, and he's been in practice 40 years, so he's not a newbie. It's not his first rodeo, but still, limited results with this patient. He's had cranial osteopathic treatment, medical intervention with allergy, immunology, cardiology, ENT, neurology, internal medicine, rheumatology, sleep specialists. He's been through massage therapy and physical therapy. I don't know if I would do all of this. I mean, it's a lot to go through, especially since he spent his own money on a lot of this. And what can you say? I give him my hands of high signs on it. He's diagnosed because of all this problem with all of a sudden with scleroderma, which is a connective tissue autoimmune disorder. So you can see that the low oxygen states in this patient starts to cause other challenges in the immune function. And of all the people that looked at him, it was only myself and the sleep specialist that decided that there were actually airway issues going on. There's nothing that supersedes oxygen into your body. I don't care what you do to this patient. I don't care if you adjust them. I don't care if you give them drugs. I don't care if you take them and stand them on their heads and have them spit nickels. It is the most primary thing that you can do is oxygenate these patients. So here's his symptoms. He's got dizziness, which is really not vertigo. It's pretty much a feeling of he's off balance. His proprioception is limited. And he's got brain fog. He's worse with forward posture. Anytime you see forward posture, you have to assume that these patients don't breathe very well or they have some sort of other distress into the system. And sitting on soft seats with his heads tilted up or down causes these symptoms. So it's very kind of strange stuff. He's got debilitating recurring problems on this level, and he couldn't work for 2 months in 2008 and 2016. Before I saw him, he's on temporary disability. He's got chronic neck and upper thoracic problems because he's in forward posture. Well, if you hold a 30-pound bowling ball out here with 50 pounds of gravity, you're going to have neck and low back problems. He can't go into upright posture because he can't breathe, so you'll see these patients go into forward posture because of that. His past history is big. He's got a breached birth, so right from the get-go, he's got challenges going on. He's got, he fell off a cliff at age of 8, fractured the C7 spinous after landing on his head. At 10, he fell on a skill saw and had multiple stitches into the back of his head. I mean, you forget about these things. He basically forgot about it until I really questioned him. At 18, he's in a camper vehicle that's parked on ice, and the thing slips off the ice and starts to tumble. Now he's got head and neck trauma, and he starts to develop migraines and insomnia at this point. So we're escalating the situation. And he's also got a history of nasal sinus infections. Anytime you see the mucosal layers of the body challenged, the nasal, throat, gut, urethral tract, bowel area, it's this mucosal barrier. It's the immunoglobulin center of immunoglobulin A that prevents the outside world from getting into the inside world. So if you have this is leaky sinus syndrome. You've heard of leaky gut syndrome, leaky brain syndrome. This is leaky sinus syndrome. This is the outside world getting in, and now he doesn't have any problems through the ENT checking him with nasal problems. He's clear there, but when you thicken the tissue, the mucosal tissue here, you have less room to get this oxygen through his nose, so he's more of a mouth breather. And when you hear your patients speak, you'll notice that a lot of them are very nasally. It's another clue that there may be something going on. At age 21, because he's compromised so much, now he's got tonsil and adenoidectomies. They removed that for him because it's so thickened with the irritation of low oxygen states. And in 1998, he was diagnosed with twitching and snoring with mild sleep apnea. He doesn't go into phase 3 or 4, and he has got frequent limb movements. So they gave him a CPAP machine. I checked his pulse ox unit, his pulse ox with an oximetry device that you put on the finger. If you don't have that, I really recommend you get that for your patients so you can see who's got oxygen saturation. He's normal all the time, but his sleep is really improved with this thing, and while there's only 25% compliance with these CPAPs, it's very helpful and it's 100% effective. So in spite of it, though, he starts to have heart palpitations. In 2010, he goes to the cardiologist who says, now you've got ventricular hypertrophy. Well, his heart's enlarged because he can't get enough oxygen to his system still from somewhere, and so the heart muscle starts to increase in size, and now he's got ejection fraction changes at 67% of normal. This is a young guy. Where do you think this guy's setting himself up for a heart attack or a stroke? The EEG test showed high brief voltage bursts of alpha activity, and that is fight or flight. This guy is in distress. So a lot of people wake up in the middle of the night and say, I have to go to the bathroom, which he says he does. But what he's really doing is his brain's waking up and saying, you got to breathe or you're going to die. And that's what wakes a lot of your patients up, especially the ones that get up 3 or 4 times and say, must have drank too much water. Nope. Part of it, I think, is airway issues. His MRI of the brain and head are normal, so that's great because there's no pathology that's set in at this point. I did all these findings on him. I found all these things on him through SOT procedures. The main things I found were him that he didn't have any category 1, 2, or 3 specific things because there's no leg length changes on this guy. He did have an SB+, and he had forward posture, and he had some cranial side bending with rotation on the left with left temporal internal deviations and left deviation of the jaw. So there were some craniofacial issues going on here. So what did I do with this guy? You know, there's so many places we can all start, and as practitioners, we all have our own flavor. But again, bearing in mind that this is an oxygen-based problem, and because the mucosal layer of his nose is thickened, and he's got a dental appliance in his mouth to keep his tongue out of the way, and he's open from that angle, I used some ballooning techniques to actually open up the airway using some arginol, which is a silver-colloidal protein that we use to coat the balloons, and that was good enough to kill any bacterial aspects, so it handled a lot of his sinus problems for him. I balanced out the SB Plus with SOT procedures. I worked on his TMJ dysfunction through intraoral procedures. I fixed the spinal areas that needed to be fixed. I worked on these muscular issues. And I always ask my patients to bring in their last blood test, because if you look at his complete blood count, you don't have to be a genius with blood chemistry. You just have to look at this and see, are they low or are they trending low? He had low red blood cell count, which basically means he can't transport oxygen in his body, which means that everything else that we're doing is for naught. So I gave him some methylated B12 and folic acid because I don't know if he has an MTHFR problem, which is methylene tetrahydrofolate reductase problems. They're genetic issues, which is in 4 out of 10 patients right now. So you could give B12 and folic acid to all of your patients and not hurt them. What that does is it increases the red blood cells. It stimulates the bone marrow to make red blood cells. That's why they feel better, because they have more energy, because they're getting oxygenation delivered through the rest of the body through the red blood cells. I have to consider the autoimmune issue because he's got the scleroderma issue, and there's still a lot of testing, so this is an ongoing case for me. He's continuing to use the CPAP, and I sent him over to a physical therapist to help him improve the forward posture lean, so he's doing better on that level. He's able to return to work. He's able to sit for 15 minutes longer without any brain fog, and for now, he can get up and move around if he starts to have this issue, and he can make the dizziness or the off-balance feeling go away, whereas before it would take him a day or two. He's able to return to rock climbing to get better with, to help his stress levels, and he's able to travel and work internationally. He's a computer guy, whiz extraordinaire, and he travels all over the world. So for me, in conclusion, really, the most important thing for this is not so much that we reduced his symptomology, but he's more functional. His ADLs are much better. And although subjectively he's only about 50% better on the pain scales, but that's likely due to some of these other factors that we haven't really explored yet. His airway is better, as I said. He's got less postural issues. His skeletal pain is reduced because he's more upright. He's not in that forward posture anymore. And his biochemistry, like I said, and immune function have to be further assessed. In conclusion, really, the keys to improvement for this patient were twofold for me. Number one, I opened up the airway for him a little bit better because of the ballooning techniques, and I helped his TM joint with some of the intraoral problems. And I used methylated B12 and folic acid to increase his red blood cells to carry more oxygen. Nothing more primary than that. So in conclusion, for me, I think it's very important that we always assess posture. Anyone standing in forward posture is a problem. Anyone who's had braces, those are people who don't have enough room in their mouth, and they're kicking the teeth out into different positions because they don't have enough room for that tongue to sit in the right position. Always assess sleep and airway. If you don't know what to do with this, I'd be happy to talk with you more about it. Always give your patients an Epworth scale. It predicts who is going to possibly have an apnea condition, 1 in 15. And always look out for your patients. Always ask for a blood test to see whether or not they have anemic tendencies, or get a 23andMe test to assess MTHFR challenged patients. So that was a mouthful. I really appreciate your attendance here, and again, thank you to Charles and Richard for making this happen. I hope you enjoyed this, and I hope it helps you in your own practices.